We just got our blood work done.
Yeah, we did.
And our doctors asked us, what are we doing to have such great blood work?
Yeah. And you know what we told them?
ProCare!
Oh my goodness. Yeah, we told them like, yeah, we take ProCare every day because they have a multivitamin that you can just take one a day.
Yes, exactly. They have a capsule and a chewable form. And not only do they have vitamins, but they also have calcium chews.
Oh my God, they're so good.
They're so delicious. It's like our own little sweet treat for the end of the night.
It really is because they have the dark chocolate and they have the cinnamon roll.
Yes, and I love the salted caramel and the dinner mint.
Alrighty, we'll go to procarenow.com
and use code OSLP at checkout to save some money. You guys ask us all the time, what is our favorite protein powder?
Yeah, literally, we see this question every day.
And the answer is always
Devotion! Yeah. Oh my goodness. I even used it this morning to make my own sweet treat for nighttime because it's just a brownie batter pudding. And you literally just use 1 scoop and then milk or water.
And then I use it every morning in my coffee. It's so delicious. Oh my God. I want one right now thinking of it.
Seriously, it's 20 grams of protein. So go get yours now at devotionnutrition.com.
And use code OSLP to save some money.
Okay.
Did it not show up?
It showed up.
Oh, okay.
You
look shocked again.
I'm always shocked. I think it's like seeing it. I just like seeing that huge line that I know I'm going to edit later and that you're going to sync up all nice and pretty. Makes it so easy to edit.
Whatever floats your boat, Mel.
I'm just prepared for future me. She's going to be excited about that clap. So
not many people can say that.
I know.
Yeah. Yep. All right.
Well, Eric, this is what you have to deal with for the next hour and a half.
That's good. It's all good. It's a pleasant change.
Good.
Welcome back, OSLP family. Yeah. Welcome.
You are listening to our Sleep Life podcast, and this is Kelly.
This is Mel.
And we want you all to pause this right now and go to baridiaries.com and buy tickets if you are in the Texas area, because we are going to be in Austin the 25th through the 27th. The show is actually on the 26th.
Yeah.
Doors open at 7.
And they're only $35.
And they are only $35.
Yeah, bring a friend, have a date night.
Yeah, and no matter if you are pre-op, post-op, just thinking about surgery, have a friend that's gone through surgery and you kind of want to feel it out, like whatever it is.
Because this is like a lifestyle podcast, you know, like you're going to learn all of the things and all the aspects. So supporters out there, come hang out with us.
Yes.
And then the other one we're going to be at is in San Diego. Yes. Freaking so April 29th.
I'm so excited. I just want the sun.
I know.
That's what it's like the sun and meeting you guys. They're like neck and neck.
I know. It's like dumping buckets of rain today.
Oh my gosh.
So the sun.
Oh my gosh.
I want to see.
I actually took your son. So I picked up Mel's son today from her brother's house, drove him here, and there's a huge puddle.
Okay.
In the parking lot behind your house.
Yeah.
And I drove really fast through it because it was just fun. And I've never seen a giant puddle like that behind your house. So I was like, well, we're going to drive really fast.
What was Dylan's face?
Oh, well, I parked first and then I was like, oh, I should have driven really fast. And he was like, oh, and I was like, you still want to do it? Like, I'll back up. So yeah, I backed up and drove really fast and then turned around and came back and did it again. So
very, very
I covered my car in water.
Hey,
Marshmallow got covered in water.
At least in San Diego, there won't be any rain.
Yes.
Or that to do because I don't really like going through puddles.
Oh, that's fun.
Yeah.
It's fun.
So yes, go to baridiaries.com for the April 29th show in San Diego. $35. So come hang out with your girls.
Yes. And then if you want more exclusive content, episodes early, YouTube videos early, because our patrons get them 10 days early.
Yeah.
Go over to patreon.com/OSLP and pick your tier. We have tiers all the way from $1 to $50, depending on whatever you want out of that tier. And there's also exclusive merch.
Yeah, my favorite part is the benchies.
And the benchies.
That's right. We have a support
How can we
group.
forget about the benchies.
Yeah, there's like 80 of us in there, almost 90.
Yeah, I was going to say, we're getting close to 90.
I know. We have a Facebook group and we hang out all day long and we talk to each other, tips, tricks. We have a couple people that just got surgery today.
Yes.
One of the girls got it today, Savina.
Yep.
And yeah, like she was telling us how it all went. So like we can be right by your side while you guys go through this. So go join.
Correct. And we have the world's greatest admin, Tanya. So shout out to Tanya. She is our typer when we are not around. She is answering every question as much as she can. And she is a great role model for everybody because she has rocked the sturdy. So
yeah, she has.
Go over, sign up, become a patron, become part of the winner's bench. And where else do they need to go, Mel?
They just need to go to YouTube. This is a free way to support your girls. You just literally need to hit subscribe and the bell. Then we get notified when these drop because what we're about to show you here in like a couple seconds is a very awesome guest. And if you're on YouTube, you get to see who this is.
Yes.
So definitely go over there and hit subscribe, ring the bell. Every Tuesday, a new episode drops.
Yes. So our guest today is Dr. Eric from the 1,000 Pound Sisters.
Yeah.
Like, can you freaking believe it?
This is exciting.
So welcome on, Dr. Eric.
Thanks for having me.
Yeah.
Good seeing you guys.
Yeah. We're so excited to have you on. So excited to talk about all the things.
Yeah. Well, and I noticed what I love about like your Instagram was I was noticing the robotics part.
Yes.
And I was like, oh my God, you can do this with robotics? No freaking way. Because me and Kelly got to see one that was laparoscopic. So
we want to know all the things about the robotics.
Yeah.
Little known secret, Melanie's actually scared of robots.
I am scared of robots.
Yes.
So not clowns for you, it's robots.
Yes.
It's 100%. Gotcha. I don't want things starting to talk to me and move and take over things.
Well, we'll probably put you at ease.
Sweet.
These aren't those kind of robots.
Awesome. Well, then can you start us off with like, how did you even get into bariatrics?
Yeah. So, I was obviously, when I started surgical residency, I didn't know specifically that I wanted to do bariatrics. But where I trained, we were very involved with bariatrics, was the first center of excellence in the state of Ohio where I trained. So we had a high volume of bariatrics.
Wow.
I'm dating myself a little bit, but this is back when open bariatric surgery was still the most common way that bariatric surgery was done.
Wow.
Laparoscopy had started to penetrate the market.
Okay.
But I was seeing it from both ways. And we definitely weren't able to offer laparoscopy to everybody, lower BMIs, less complex patients.
Okay.
And I'll be honest with you, at first it was the challenge of the surgery. You're doing a very complex surgery, specifically laparoscopically, on patients that many other surgeons see are more challenging, difficult surgeries to do. Let's be honest, us surgeons, we're all a little type A ego driven. If somebody says it's not easy to do, then we're like, oh, I'm going to show you.
Yeah.
And I want to do it really well.
Yeah.
So the challenge was there right off the bat. Robotics really wasn't, I wasn't exposed to that during my residency. And it was kind of a unique situation where when I started seeing laparoscopic bariatric surgery, I thought, man, if I can learn to do that, I can learn to do anything.
Okay. Yeah.
And as minimally invasive surgery started penetrating the bariatric market, as I said, they brought in a new fellow from training to kind of teach the group there that had been doing it open for years how to do it laparoscopically and offer that to patients as they learned kind of as they go. And making sure they did it the right way. And I was in a situation during my residency where I got the opportunity to be chief resident for 2 years. We were in a program where there was 2, 3, 2. It rotated, so the year ahead of me was 2 residents. My year was 3. And one of the residents the year ahead of me had left to go do a fellowship.
Oh.
So he needed someone to do it with him for during his chief year, his 5th year. And I got asked to be chief with him as a 4th year. So I knew my case volume would be very high. And so this new guy was out of training that joined our trainers. I just went to him and I said, look, you're going to get a medical student driving the camera for your first 50 cases here, fresh out of fellowship. So I'll bypass doing these surgeries that I know I'm going to have a ton of exposure doing. and I'll come drive the camera for you as a 4th year resident, but you got to teach me how to do these.
Oh.
And he said, you do that? And I'm like, absolutely. He said, deal.
Yeah.
So I kind of swallowed my pride and stood there like a med student holding the camera as he started. And then he's like, okay, I kind of paid my dues, and he started showing me how to do them. So I came out of training with a ton of exposure, really more so than I would have gotten in a fellowship at that time. But what was really cool is we have our residency clinic where we took care of patients who at that time didn't have insurance and things like that. But I got our attendings to start a bariatric surgery clinic for our residency program.
Nice.
Like, what about patients who need bariatric surgery, not just somebody that needs their gallbladder out or their hernia fixed?
Yeah.
And so not only did we do that, but we also were able to offer laparoscopy for, at that time, the people who are good candidates for it.
Okay.
Wow.
And, it was a great opportunity for the residents. It was a great opportunity for us to get to maybe impact patients that maybe would have never gotten a chance from a financial standpoint or whatever to have bariatric surgery. And that's when I really got, as a resident, you don't spend as much time in the clinic. You're just operating and taking care of everything that comes in the hospital.
Okay.
But I got a chance to see these patients and the impact that it had on their life. And then I was just hooked. You know, I mean, I tell people all the time, I hate to say it, but I feel selfish as to why I do this, because I love how it makes me feel, but it's because of getting to see what happens to people, and how it changes their lives. And obviously helping them from a health standpoint is great, but to see how it impacts their family, their job, their well-being, their mental health, everything across the board. So once I started doing that, then I knew that's what I wanted to do.
Yeah. The rest is history.
Oh my goodness.
That's so cool, because I kind of feel like that sometimes, like the selfish part of it, because we love hearing the stories of like us impacting somebody enough to get surgery or feel confident enough to, tackle this journey, or the fact that they felt prepared for the journey. Yeah. And so I can relate to you on that, and not on the surgery aspect of it, because that is not my forte, but you let me talk, I'm good. And so it being a part of this community in such a impactful way is just so, like, it gives me chills sometimes when I think about it, of how much somebody can do simply by putting the patients first. Yeah. Because that's what we need. Instead of, focused on the money or, the exposure or anything like that. Like you're really just putting them first and saying, I know how you feel. I know that you're probably sick and tired of being fat and unhealthy. Yeah. We're going to help you. And that means the world
to us. Yeah. Cause like, when you hear a doctor agree with you about something that you've kind of been fighting for your, well, some people their whole life, it's like, oh, thank you for finally believing that we can do this and this can be fixed, because sometimes we feel trapped in our bodies. And I know I definitely did. So finally having Dr. Patterson be like, yeah, let's do this. Here's your date. I'm like, yeah.
Yep. I remember talking with Dr. Thompson for the first time and really feeling comfortable, because she's kind of like you. She's very down to earth, but she's very passionate about her patients. And when I talked to her for the first time and I felt like she saw me and she understood where I was coming from, I legit cried. No. Because it was so finally, I can see a light at the end of the tunnel. Because when you're bedridden for many years, you just feel stuck and you're on pain meds and you're not there at all. Yeah. And so I can relate. I haven't been overweight my whole life. I wasn't overweight my whole life, but just those few years, oh man.
It was very traumatic.
It was traumatic. Yes.
Yeah, absolutely. And I think, the one thing that, I see this, and I know when I say this, you all will probably agree pretty quickly, but not only is for a patient to meet somebody who's on their side and who's saying, we're going to do this, but unfortunately, some of these patients have been hearing the opposite from physicians in the past.
Mm-hmm.
Not only is it they're not getting support, they're almost being fought about it. They're not being given support. They're not being given any good information of how they can conquer their disease.
Mm-hmm.
And they're basically being told that it's almost self-inflicted.
Mm-hmm.
So to have that 360, so you almost feel like that's your enemy and you've lost trust in somebody that you can go to feeling like somebody's there on your side. Now, everybody's not like that. Obviously, I'm a physician and I'm very defensive of our profession. There's the good and the bad and everything
there has
in
to
this
be.
world.
Yeah.
But I think it's, it's a subject that maybe there's some primary care docs. It's not that they're negative. They just don't know how to approach it.
Yeah.
They're afraid to bring it up, There's so many things involved. So I see that side of it when people's eyes light up, like finally, and they take that deep breath. And it's very,
because my primary care, what she wanted me to do, because I talked to her first about it because my brother did it. And I have titanium from knee down from like a spiral fracture that I got. So she was like, maybe we should remove the metal and maybe you should try to lose 20 pounds first. And then we can maybe talk about bariatrics. And I was like,
and what's interesting about that.
Why do I need to do a surgery on my leg?
Right.
So I can
interesting.
See, right? So I was just like, no, like I don't want to go through 2 surgeries.
Yeah, because my rheumatologist was actually the first one that told me about bariatric surgery. Like I knew Mel had it, but I didn't know anything else other than that. And she actually brought it up on 3 separate occasions. And on the second occasion that she brought it up, I actually went to my primary care and was like, because my rheumatologist doesn't do referrals for that. Obviously, she's my rheumatologist.
Yeah.
But so I went to my primary care and I was like, hey, so my rheumatologist is saying like this would be really good for me. Can I get a referral to a bariatric surgeon? And she was like, well, I don't think you're there yet, which I was 270 pounds. Like with several autoimmune diseases. Probably should have been the first place. So she sent me over to a weight loss clinic where they like help you with your eating and stuff. And I was like, that's not what I need right now. Like I need something that's going to be like permanent within my life. I've done all those diets. But I was like, you know what? That's what she's sending me to. So I will do that. And I called. The lady was so rude to me on the phone. So like dismissive of me that I was like, nope, something in this universe is telling me this is not where I need to be. And I didn't end up going and ended up getting a referral from my rheumatologist to the bariatrics center. Because I was like, listen, my primary's not listening. I need something else. And I was an advocate for myself at that point because I could have just, not gone to either of them and just continued to gain weight and be miserable. But it sticks out in my brain because I'm just like, really? Like you couldn't have just said, yeah, let's send it over there. Let's see what happens. Yeah. Because there's nothing wrong with seeing your options.
No.
It's one of the first things when patients come in, they kind of have the way we do it at our clinic is we have intake day. And intake day is like patient's first day.
Okay.
We'll have a room full of patients and they spend most of that whole day there where they have classes from the get-go, our dietitian, our bariatric nurse. They meet with the MPs and the PAs. They meet with the insurance coordinator. They learn all about, okay, like here's what your insurance requires. Here's your homework and here's the things we need to get done and all that stuff. And I meet these people in a group and talk to them about very, general concepts, really just kind of an introduction. But one of the first things that I make sure that I tell them is I don't want you sitting here today and feeling like you failed. Like, oh my gosh, it's come to this. Like I'm here. I had to see a surgeon.
Right.
And so but the only way you can fix that is to throw some facts at them. Some aren't like that. Some are really excited, but there's a lot of people you can just see it in their face. They've heard it from friends or family members, maybe their primary doctor, like you said. And I make sure they know the most important stat out there it blows my mind that it doesn't get talked about enough, especially in the primary care world. And that's, if you're morbidly obese and you do diet and exercise alone, Your chances of losing enough weight to get out of that obese category and keeping it off for greater than a year is 1%. If you're a male, it's 0.5%.
Yeah.
And I'm from Eastern Kentucky. I'm kind of black and blue, meat and potato.
Yeah.
It is what it is. Yep. And my thing is, if I'm going to go play the lottery, let me know my odds. And if you tell me my odds and I choose to invest, then that's on me. But if you don't let me know what my odds are and you mislead me, then that's on you.
Yeah.
And I tell them, look, that's your odds. How many times did those doctors that told you eat right and exercise, did they follow that up? And oh, by the way, here's your chances of that working long term.
Never.
Doesn't mean that you're not supposed to do those things. And I'm going to tell you today, you have to do those things with my surgery. But if you do those things with my surgery, you go from 1% at 1 year to greater than 50% at 5 years.
That's amazing.
Oh, I just got chills.
If you blind those two things and say, which one would you pick? Your family that questioned you coming here would say, take the 50% at 5 years. And okay, well, and behind door number 2, it is bariatric surgery.
Wow.
And, and I always follow that up and say, you're going to have a family member say 50%. That means 50% fail. No, I didn't say that. I'm saying 50% are out of the obese category. You still may have other people who were 500 pounds are down to 285, 300, but they're still not out of that category. I can't count them, but how much better off are they?
100%. Because I'm still in the obese category. I looked it up when one of our benchies did the BMI, and I was like, for my height, I'll never be out of obese category.
Right.
Don't say never. Don't say never.
No, like it's like 145, Kel. It's like
stupid. No, you looked sick at 170.
I know.
Yeah, no. Okay, so
well, BMIs aren't perfect. And people ask that all the time. And so we have to take that into consideration. You could have a bodybuilder walk in your office and be an abnormal BMI, and anybody with any ethics or morals would say, no, you're in the wrong place. We're going to get you to a psychologist, not a surgeon. But, I think it's so important to tell people that. And I also think that somehow we've gone wrong with making that message known to primary care, because guess what? That's who you as patients trust. You see them for your colds. You see them for your headaches. You see them for if you have an emergency, all those things. I'm the new guy, and that's who your rapport is with. And we've got to find a way to get that message across better. Correct these misconceptions, whatever it may be. So they're guiding people to make them healthier, and I think there's so much work we can do on the bariatric surgery side, whether it be ASMBS or anything. We treat barely over 1% of the population in the United States who qualify for surgery. Think about that.
It makes me so mad.
I know. If we can just double that and triple that.
Our awareness has to change dramatically.
Yes.
I mean, there's so many people out there that could use this surgery. What's really funny is that, so my boyfriend actually had bypass a month before I did. This was like, I didn't even know we were going through the surgery at the same point until later. So he rarely talks about his surgery. Like he's just not like, he's a guy. He just doesn't really want to share that. And I'll kind of throw him under the bus. Sometimes I'll be like, yeah, we both had surgery. But he now comes home and will tell me about, like, he was talking to somebody and was telling them that he had weight loss surgery and blah, blah, blah. And so him dating me, seeing me talk about it all the time, has now he's getting to the point where he's like
more comfortable.
Yeah. And
you made me more comfortable talking about it.
True. That's a good point.
100%.
Because I'm like, I don't care. Like, if you don't like me because I had bariatric surgery, well, I'm still happy.
She does tell people anywhere.
I have told gas attendants.
So I'm like, Kelly, these people don't even know us from Adam. Like,
I don't really care.
My surgery business? I don't know.
Yeah,
this feels weird.
I was at a gas station getting my tank filled, and the guy's like, so what are you doing today? And I was like, oh, I'm recording for my podcast and blah, blah, blah. And, I'm like, he's like, oh, what's it about? Well, it's about weight loss surgery. He's like, oh, so you got the band thing?
It's always the band thing.
Okay.
Always
so now we're going to have a lesson. Sit down. We're going to tell you. So I'm like telling him the difference between each of the surgeries. And like, I went through a whole course with him. He had no idea what he was getting himself into. But I've done it in grocery stores. I've done it.
We were at a convenience store when you did it with me.
Convenience stores. No. Like, I don't care because I want everybody to know. And I tell them, like, this is the hardest thing I've ever done in my life.
Yeah.
And it's not the easy way out. Like usually the first thing out of my mouth is, this is not the easy way out.
Yes. Stop it right now.
Be prepared for that, because a lot of people are like, oh, so you just had surgery and lost all the weight. And it's like, oh, if only it was that easy.
I know.
Please. Easy button. I would totally say it was easy if it was like push the button and all the weight fell off. But that is not how it works at all.
It's real work. That's the deal.
Yeah.
It's actual work. But you have to take care of yourself literally all day long.
Yeah, exactly.
Well, it's even harder because not only do you have to do the two things that people are saying isn't the easy way out, which is the old fashioned way. You have to do that. Plus you have to go through all the preparation, surgery, learn how to eat differently and all that stuff on top of that.
Yeah. And you have to worry about regain, which is a huge, speaking of failure, because you were saying how people, when they get there, sometimes they have that failure. That's the first thing that people think when they think regain.
Yep.
Is I've failed.
Immediately. Right. And it's like, no, you didn't.
No. And I mean, I'm battling regain right now, but that doesn't make me a failure.
No.
Look at where I came from to where I'm at now. Yeah, exactly. Yeah. You're allowed to kind of have some hiccups, and then you pull yourself together and you realize why you did it and you move forward.
Well, and I feel like bariatric surgery is really some like the science and the health and the surgeons behind it. Like that's what we need to know when we're kids. This is information we should have been taught when we were in like adulthood, like young adolescents. Like we should have learned how to prep our fucking food and not know, like, because our parents, a lot of it does come from our parents. My mom listens to this and so does your mom.
Love you,
and
moms.
This is not a diss on our moms, but like, like they're the ones feeding us and we only know what is in front of us. Like they literally are our role models until we meet other people. So like,
absolutely,
we have, it has to be done in the kitchen in your own house. Like it sucks, by the way, to do this afterwards. Like this is it's harder work to learn in your 30s and 40s how to eat, because you've already trained your body into this whole dynamic of how to eat. And now you have to go like, nope, we don't do that anymore. Well, like that's really hard, like for your brain to like switch gears.
Yeah.
So that's why it's not the easy way out.
For me, I ate healthy my whole time growing up. Like my mom made very healthy meals. She was very conscious of it. And it was when I got out of the house and I could then afford to eat whatever I wanted. Then I went to fast food, because I had never been able to have fast food.
Right.
Because, single mom, 4 girls, you're not going to fast food every night. You're just not.
No.
Right.
And so I made the choice to start eating like that without the knowledge of, oh yeah, this is going to make me fat.
Yeah.
Like if I eat like this and then drink, a bunch of beer at night every single night, that's not a good combo.
No, like they just, the knowledge just needs to be more in our schools.
Present.
Yeah.
I don't think we've seen that anymore. I was on another podcast with a group out of Austin, and I don't think we've seen this any more than we have with what we've just dealt with for the past 2 years with COVID.
Yeah.
The one factor that is the most predictive of if you're going to have a poor outcome with COVID, whether it be hospitalization, intubation, or death, is obesity. Like
Number
it is
one.
Clear as a bell. You'll not get anybody. You can get everybody that can argue about everything about COVID, but the one thing that they'll see that is in common is that. And, so yes, we have to find a way to deal with what we've been dealing with and how we get through that, and whether it be prevention, vaccination, all the things that are involved. And you could talk about that for months, but when are we going to get to the underlying problem? When are we going to say there will be another COVID? There will be another flu type of some sort. There will be another illness.
Right.
And in medicine, we've always seen that obesity is a predictive. You come to me you want me to fix your hernia. I'm going to tell you that one of the number one factors that will cause your hernia to reoccur and you'll have a mesh complication is being obese. We've known this is associated with so many other things for years, but when are we going to talk about how do we put people in a position when they do get sick, they won't get as sick?
Yeah.
When do we invest dollars and resources? And as you said, education to say, okay, let's get ourselves out of the acute bind, but what are we going to do for the next 10 to 15 to 20 years when the next one comes around that we got this new problem, but people aren't dying from it like they were before. And people aren't hospitalized where they were before, and we're not overwhelming our resources.
Yeah.
And it gets very frustrating because it is basic education. walk into a cafeteria at a school, nothing's changed.
No,
you know,
no.
Wherever that may be. So I'm 100% with you.
Yeah, because it's like if you do the prevention, all the work in the front end, you're going to pay off in the back end. And so these people you're not only just saving lives, you're saving dollars. And I don't understand what is going on with our economy to where they just don't see that. It's very black and white.
Well,
if you just look at it.
I just don't think they care.
It's either they don't care, they just don't. They're just having blinders on. They're just acting like it doesn't exist.
Well, I mean, especially, you think of the school system. And, my boyfriend's daughters, I'll be like, oh, what'd you have for lunch? Hamburger and fries.
Pizza.
What?
Right. Yeah.
Why?
Yeah.
Like, there's so many other options that are out there for good food and all of them agree it's crap food. Like, they don't even like eating it. So why are they serving it? And if you start in high school, because that's when you start really making your own decisions and you're really starting to learn,
I say elementary because they make them even have those milks and they all pour them out and never drink them.
I know.
It's so weird. It's so weird. Like, you have to have that milk. No one likes it. They all dump it.
They don't drink it.
Right.
Yeah. But
why are we wasting milk?
But high school, you're really starting to like develop those adult thinking patterns. They're starting to get jobs and drive. And, especially with Bianca, she's 16 now. So she has a job. She drives. She's starting to realize the whole like we went to the beach yesterday without her because she was working and she was so mad. And she was like, you guys went to the beach without me. And I was like, well, you were working. And unfortunately, when you have a job, you miss things because and she's like, but I have to work. I have to pay for gas. And I'm all ding, ding, ding.
There you go.
That's what happens. Cause she's like, well, I can't drive my car if I don't have gas. And I'm like,
you're right.
That's exactly it. So it's like, we almost need to teach like that. Like, if you have this is the direct result of it.
Right.
Like, if you eat these ways, and telling the reason why, like, why is water important for your body? Why is protein helpful? Like,
exactly.
Yeah.
I'm a big advocate of when I do all the education with my patients is I always say, I don't tell my kids because I said so. I'm not going to tell you that either.
Oh,
yeah.
I'm not going to ask you to do a pre-op diet because I said so. I'm going to explain to you why you do a pre-op diet, what happens to your liver and how that works.
Yeah.
I'm going to tell you why I'm asking you to do something and give you the science behind it, because then I'm not giving you a list of things to memorize. I'm giving you things to understand. And it just seems natural why with this surgery that you chose, if you eat these things, it may sabotage it, or you may feel this way after you eat that or what have you.
Yeah.
And I think it's important to teach people why. I think it shows respect for them when you want to give them the knowledge of why and not just give them do this. And I think that happens a lot in medicine. We're probably guilty of that as physicians sometimes, but I really think it's important to teach people why. And, we can say, don't smoke, it's bad for you.
Right.
You have to go to the next level and predict to them what may happen to them. And so when we talk about obesity, we have to talk about, here's your risk of malignancy if you stay obese. Here's your chance as a female of getting breast cancer compared to the other person. If you're obese and you're a diabetic, you have like over a 300% increase in developing cancer if you weren't obese and diabetic. You have to tell these things that really it can't be just it's bad for you. You have to give people, I think, the why. And I really appreciate that you brought that up because I think that's what people want. And I think it makes them feel acknowledged and respected when you do that.
Well, definitely. It makes them feel more comfortable about the decision they're about to make.
Correct. I would agree.
I know I did. When she was talking about the liver shrinking diet, when she explained why she has to do that for the type of surgery she does, I'm like, that makes sense. Okay, I will be helpful.
Right.
Yes. I will make sure we do understanding is such a huge deal. And kind of want to go back to like, what are some of the common things for being obese that you do see in like your later years? Like, what are like the top 5 or 6 things you can think of?
You mean as far as other comorbidities that come along with it, or the downside of it? Well, obviously, in general, immobility is influenced by that. But obviously, the big ones linked to obesity is heart disease, diabetes, sleep apnea. Those are some of the big ones. A lot of the metabolic syndromes that we're learning more about now that really is that triad of affecting insulin sensitivity, the coronary artery disease. Diabetes sounds like a terrible thing, but it's not just the diabetes. The uncontrolled diabetes leads to the renal failure, the peripheral neuropathies, the retinopathies, all the other things that come with it. That, it's one thing to be taking insulin. It's another thing. And oh my gosh, I need a kidney transplant. I'm on dialysis because my kidneys have failed because my diabetes is so uncontrolled.
Well, and how do these people feel with these like diseases? Like they're not feeling energized, right? Like
no.
Right,
and so it all piles on, and they lose the ability to do any form of activity. And I think what happens too is a lot of those diseases, especially diabetics. I preach to my patients body composition a lot. I make them. We have a body composition. I don't even like to call it a scale, a body composition analyzer, if you want to be specific.
I like that.
Where they look at their weight, but their weight is really just a small piece. It is their body fat mass and their muscle mass. And, I can make anybody lose weight, but am I making them healthier? If they're tanking their muscle mass, they don't change their body composition. It's harder and harder to keep the weight off. We're seeing now that retention of muscle mass is one of the best predictors of keeping diabetes away, years out after you've lost the weight. So, making them understand that. And when these people get so immobile and they're short of breath and it just piles on and their body composition switches in a way that it gets more negative and negative when it comes to, body fat mass to muscle mass. And then they might be eating less than they were the year before, but they're actually gaining more weight because that body composition influences their calorie number.
Right.
I tell patients, you all have a number right now, today, at your current body composition, you have a number, and that number is, if you go above it, you gain weight. And if you go below it, you lose weight. It really is that simple. It's not simple to do, but it's raw science. And what we have to find a way is not only how do we get below that number in a healthy way to help you lose weight, but how do we influence your body composition where 70 pounds lighter, you're actually allowed to eat as much, if not more calories than you could when you were 70 pounds higher, because we flipped your body composition.
That makes sense. Yeah.
That's so cool.
Yeah. This is why I like science, guys.
Well, okay, Mel.
Well, because of the numbers, like once you figure out how it works, then you can start doing the stuff you need to do for your own body. Because I would.
So no, go ahead.
No, you're good. I lost it right after. So you're good.
Well, I think I get so frustrated when I hear you'll hear somebody, especially a patient who's a higher weight, and that's a great conversation too, because I think we focus on that so much that we ignore, like you said, your doctor told you weren't there yet. And we could be helping so many people who are less than 300 pounds, but they qualify for surgery and still have medical problems. But, that's a whole nother talk show in itself. But,
yes, it is.
To be able to, when you see these people who are severely overweight and people say, oh my gosh, they must eat 10,000, 12,000 calories a day.
Right.
No. I have patients, I can think of a specific male patient that for certain reasons, you all would know who he is, and he doesn't care me sharing this story. But when I first saw him, he was over 435 pounds. His calorie number was within 150 calories of my calorie number.
Wow.
So he could eat the same number of calories as me within 150 and stay where he was, and I'd stay where I am.
That's crazy.
There may be days and he would admit he ate way more than he should.
Right.
But my point is it's not this, somebody's bringing them food and they're just eating nonstop.
No.
And as their body composition worsens, that number drops even lower. So you're exceeding it more and more. When you feel like, gosh, I feel like I'm trying. I feel like I'm not eating as much.
Well, yeah, because isn't it you're resting calorie burning, like everybody has a number of what you would just burn if you didn't move all day, right? So if they're hitting what they are in calories for eating and they can't move, then that's why they would gain weight, because now they can't move anymore. So the number changes.
Yeah, that's a good point.
Yeah.
That's crazy.
Huh. So now is that resting calorie rate, is that the same for everybody? Or does that change versus person to person?
Oh, that has to be person to person.
So there's an equation that you can look up.
Okay.
And it's a bunch of different numbers.
Yeah.
You'll see it also categorized as a BMR.
Oh, okay.
And so you can look that up. You can get online now and put your information in a calculator, and it's pretty daggone close. And so, cool. How do you create a deficit? By burning it off or taking less in. Now we all know all calories aren't created equal,
right?
Mm-hmm. You can't. Okay, I'm only going to eat 1,500 calories, but they're all simple sugars and processed foods.
Mm-hmm.
That's not going to work.
Yeah, no.
But yeah, and I think it's good information to give people to start with, and we're not making them overanalyze that number, but if anything, it makes them feel like, I'll sit with them on the visit before their surgery and say, to a female who's 5'6" and she's 275 pounds, I'm like, your calorie number is only 1,350. See why it's been so hard for you to lose weight?
Yeah.
So we're going to make you aware of this, but we're going to actually, we do this the right way, 50 pounds lighter, you might be close to 1,500, or even if you're still at 1,350 and you're way lighter, how awesome is that?
Yeah.
That's crazy.
So, but it also motivates them to maintain their muscle mass, get their protein in, don't deplete their protein source, stores as they start losing weight, and not get fixated on, I lost 5 pounds. Well, where did you lose it from?
Yeah, that's a better way to help, like the body dysmorphia part, where like, no, you've lost it. Look at the compensation. Like, yeah, I said that word wrong, but that's
compensation.
Thank you.
Yeah.
Okay. I was like, wait a minute, that didn't sound right. I'm like,
right.
How many times have you said, I'm sure you like, I don't feel like the number changed, but my clothes fit better.
Yeah.
You hear people say that all the time.
Oh, I did it.
We can explain that to them. Well, we've all heard muscle weighs more than fat, and that's very true. But if I've dropped your body fat percentage by 1.5%, and you've added a muscle mass, your overall weight number didn't change. But the reason your clothes fit better is because you're now moving towards a more balanced body type.
Yeah.
So I'm wondering, because I saw a post the other day about somebody was in a stall and they were like, can you guys give us some tips on how to start losing weight again? And a couple people, did the dreaded pouch reset, like go back to the beginning, and like eat what you did then. And I was just, can you explain to me why that doesn't work?
Yes, please.
Well, there's no button in your pouch or your sleeve that we hit and it, rewinds. It just doesn't work that way. There's no such thing as a pouch reset. There's mind resets. And if the few people that it works, maybe that's why it worked for them, because they started all over and they went back to their basics. But theoretically, that actually would be opposite, especially if you want to talk about a pouch reset. So we're talking about somebody who's got a gastric bypass. Why a year later, when their anastomosis on their bypass is not near as tight as it was post-operatively, when they were on liquids, because all they could drink was liquids because solid food would have been stuck because you have swelling and inflammation. Why would they feel fuller a year later with a pouch that's wide open compared to what it was when they were on those liquids the first week? Now think about that. Makes zero sense. But I think the people that it works for, they probably just get their mind right. They start from scratch. So it's a mind reset. There's no such thing as a pouch reset.
Then they need it. We need a reverb. We can change that.
We can change the reverbiage on that.
Yeah.
So is it doing more harm than good if you're going back to, like, they say, okay, I'm going to do 2 weeks of liquids again?
Yeah. That's what we're seeing people do.
There are situations, I tell patients all the time, it is as important for you to advance your diet as fast as I say, as it is to not advance it too fast. Like most people would say, oh, if I advance it too fast, I could hurt something. I could tear something apart.
Yeah.
But if people say they go to stage 2 or stage 3, they're like, ugh, feels, man, one bite, I feel that in my chest. I'm not sure I like that. I'll just go back to liquids. You may never open things up like you're supposed to. Using the word stretch to a bariatric surgery patient, they're like, they don't want to hear that word because they don't want anything to stretch.
That is a bad word,
especially
in this community.
Sleeve.
Yeah.
But we need to open for you all a sleeve to the size that it's supposed to be. So you're not getting negative feedback to your brain. I always say your sleeve's like a half-kinked water hose,
Okay.
And if you take a half-kinked, you look at the shape of it, it's like a half-kinked water hose. And if you turn the water on a trickle, the water doesn't want to go through. But as you turn the water pressure up, it will straighten out. And so early on, when you have that nausea, that's an analogy that I teach my patients. So I say, when you're so nauseous, you think the last thing you want to do is drink. You need to drink, because every sip you take, you're turning the water up. You're turning the water up. And that's going to overcome that feedback to your brain where your sleeve is kinked a little bit. It's sending the signal to your brain that you're nauseous and that you need to get rid of what you need to get rid of, but you don't. And so I've seen patients, they get so cautious and they're 6, 8, 12 weeks out and they've never started solid foods. And now they have this chronic nausea that they can't get over because they've never opened things up. And then they start developing food aversions as well, and it's very frustrating because I look at their sleeve, I scope their sleeve, we do upper GIs. I'm like, your anatomy is normal, but you've now developed this subconscious aversion to everything makes me nauseous. It smells nauseous. You have to overcome that. So Lisa, I'm not saying that people go back to liquids for a week or two forever down the road. It's going to be a bad thing for them.
Right. Mm-hmm.
But you're not fixing the problem. If you've stalled in weight, number one, let's look at your calories and where your nutrition's come from. Or number two, if you're working out, no one's ever bothered to look at, maybe you stalled because you've lost body fat percentage and you've maintained your muscle mass. That's okay. Ignore that stall and keep doing what you're doing, and it will continue to progress, because the more muscle mass you have in proportion, the higher your metabolism will run and you'll burn more calories.
Yeah.
So I think you got to get to the underlying problem. What is the stall?
Okay.
And that's why follow-up is so important. You don't try to you sit down with your dietitian, you sit down with your doc, you sit down in your support group, like what you guys have and other resources may have, and really figure out what's the stall from. It's not a juice diet. It's not a liquid diet. It's not a pouch reset. It's let's get down to the basics.
Well, and I hate it because we all have done every diet out there. Most of the time we've done juice cleanses, we've done all carbs, we've done no carbs, we've done
the egg diet,
the military, like we've done them, you name it, we've done them. And so it's like the pouch reset is just another diet that you're going back to it because it's familiar, instead of going to the root of the problem of, okay, let's look, am I getting enough water? Am I getting enough protein? What kind of carbs am I eating? What, and like you said, contact your surgeon, contact your nutritionist, figure out what's going on, because that's a really, just the whole body composition thing, you have to know, are you working out really hard? Well, then it could be muscle that you are now gaining. So, of course, you're going to stall as you work out harder and harder.
Right.
Well, and I know that we wanted to talk to you about sleep because sleep plays a factor in losing weight as well.
Right. Yeah, absolutely. And I'm as guilty as anybody of probably not getting enough doing what I do, and starting in residency, you're we don't sleep.
No.
I trained in the days where there were no work hour restrictions. You're working 120 hours a week and you go nonstop. But, and we get busy and sometimes the last thing we do is take care of ourselves.
Right.
Because we worry about everybody else. But sleep is a huge factor in your overall health, without a doubt, your mental health. But when we're talking about obviously patients battling with their weight and battling with obesity, and just some of the things that you can take and look at sleep as. Let's make it really simple. When are we most susceptible to eating at the worst time of the day and the worst foods?
Yep,
late at night, right?
At night,
and you'll have those fluctuations in your insulin and things like that. And even if you have dinner at 5. That usually hits about 8:30, 9 o'clock where you get that craving.
Yep.
So one of the easiest ways to avoid the craving is not be awake for the craving. Then there's literally studies that think that probably getting to bed early probably helps with the snacking and eating late.
Okay.
Now we can get really scientific with it too. And we can say, well, how does sleep affect, being overweight? And we know some of the hunger hormones like ghrelin and the leptin and things like that. And we know in studies where people were sleeping 4 hours or less versus sleeping 10 hours, that those hormone levels were drastically different. So that hunger hormone was produced at a much higher level for some of those people, which probably led to losing less weight or eating a poor diet.
Okay.
So was it the 4 hour or the 10 hour that was more ghrelin?
before.
So when you're not sleeping enough, your levels are being produced at a higher.
Got it. Okay.
Being produced higher.
Yeah.
So they did a study, and I can't remember where it was done, where they just took like a 14-day period of sleep deprivation versus not sleep deprivation. And they noticed that but they were trying to do other modalities to lose weight, and people lost more than 50% less fat if they were sleep deprived than if they were getting adequate sleep.
Okay.
So there's a lot of linkages with sleep. You know, people tend to be more physically active when they're getting enough sleep. I mean, think about it. If you're getting enough sleep, you're not tired the next day. If you're not tired the next day, if I need to work out when I get home, but I'm exhausted, there's less likely that I'm going to go work out than if I'm not as tired. And that is typically in relationship to how much rest I got the night before.
Yeah.
So, you know, there's scientific things, there's common sense things, but there's, you know, adequate sleep is so important. And, you know,
how much do you generally recommend your patients to get, like, right after surgery?
Well, I mean, in the bare minimum, you always want people to try to get 8 or more hours of sleep.
Okay.
You know, ideally, if you look a lot of data, people would say that it would be better if you got 10 hours of sleep.
Wow.
But we also live in a very busy world.
Yep.
And I think we can set these really high standards, but I think you have to be practical with it too.
Yes.
Okay.
And you at least set some goals that may be more realistic, because if you set goals that aren't going to be achieved, it's just frustrating, and people get mad and they quit. But, you know, right off the bat, we try to set those parameters for patients to try to achieve that.
Yeah. I never had a sleep goal. Like I don't remember my surgeon ever saying a sleep goal. So I'm kind of excited that there is that information out there of right after surgery, or even, you know, later on, you need to be getting more sleep, because that would make sense on why I'm hungry all the time, because I'm only getting 4 hours of sleep a night.
Well, and you know, when you're tired, what do we do when we're tired? We want comfort, right?
Yep.
When you're little, you want your mom or you want whoever, your guardian, you want to be comforted. You may want your significant other or your spouse or whoever that may be. But when we're tired and, oh, by the way, we're also hungry, we're drawn to comfort, and we're drawn to comfort food. And comfort food is not typically healthy food.
Right.
It's what can I get quickly? I just want to eat something that feels good to me or tastes good to me. And those are usually poor choices. And that many times is out of the fact that we're just fatigued and we're run down.
Oh, you just perfectly described me. Jeez. Oh, man. Okay. I think that is the most important statement we've gotten on the podcast yet.
Yeah.
Yeah.
I would agree. Because, like, if we should all have sleep goals. We should just we should just start maybe doing challenges about sleep, because it is so important to like I notice my mood is like the hugest thing for me. I am very, very nice when I get a lot
when
of
you
sleep.
have enough sleep. Yes. Yes.
Oh,
I definitely can attest to when you're tired the next day, the last thing on your mind is eating well and working out and doing those things that are detrimental to your health goal. Yeah. And so, but if it's one of those strange nights where I get like 6 to 7 hours, I'm good. Yeah. Like last night, I think I got about 6 hours of sleep. Woke up this morning, went to the gym.
You did.
Went home, had my water. Like I was getting everything going. I had my healthy, I did Real Good, the chicken things. Yeah. I did those in the air fryer for lunch. Nice. And I was like, I even made my mom one. And I was like, hey, Mom, here's a healthy lunch.
All this energy.
So getting good sleep. I mean, I'm now making the connection to why today was so good over normal days. Yeah. So yeah, that's
sleep is huge, man.
My mind's blown right now. So
yeah. And we're all guilty of, you know, I'm bad for, you know, I come home, I've been operating all day, or, you know, I just, from traveling, whether, you know, speaking somewhere or teaching a course or something like that. And then, you know, you got to turn everything off. You know, I'm really guilty of when I go to bed, TV's on, and that stimulus is there. And that's something I'm still working on. Because my mind is going 1,000 times a minute and I'm thinking of all these things that I've got coming up that I've got to get done, or what my schedule's like. So it's not easy. I always try to say, hey, I'm not sitting here saying this is what you're supposed to do because I've got it all figured out. I'm human just like everybody else, but I'm right there with you.
Oh, yeah. I love that.
I mean, my trick is I literally do turn everything off, and then I turn white noise on. I do like a fan, and it's like on the medium loudness. And then I literally I'm like an old lady. I got a mask.
Oh my Lord.
Put a mask on. I don't even care, because literally I'm out within like 10, 15 minutes, because the white noise makes me just go into calm.
See, and I use the TV as my white noise, because if I found, and I figured this out last night, which is probably why I slept so good. If I have a TV show that I have not seen before, or a movie or whatever, I am more apt to wake up. And even though I set the sleep timer, I'll sleep for 20 minutes and then I'll wake up. Now, I've seen Zootopia a million times. I love that movie. I don't know what it is. Anybody who has kids that understands where I'm at, there is a part where she gets on the train and goes into Zootopia. Every single time that I play this movie, before she even gets to Zootopia, I'm out and I don't wake up. So I don't know if it's just that movie or what. So Zootopia is going to be on rotation now every single night.
There you go.
And I'm going to test it out.
Noise.
Yeah, Zootopia.
You got to find what your white noise is.
Whatever it is, no matter how weird.
So when you did your fellowship, it sounds like you've actually done surgeries that you've open and then laparoscopic and then now robotic.
Yeah. So, and actually when I was in residency, there were no bariatric fellowships then. There was minimally invasive fellowships.
Okay.
And part of the minimally invasive fellowship where you might take a year and you focus primarily at that time on laparoscopic surgery, a little bit on colorectal, hernia, foregut, and bariatrics might've been a component of that. But that really wasn't a thing. Now you can do those fellowships. When I came out of my residency, the MIS fellowships, I had more cases logged than I would have gotten in a year of fellowship focused on that, just because of the unique situation that I kind of fell in. Yeah, I think I took good advantage of that as well. But but I was trained. Our MIS was laparoscopic. Robotics was being talked about. It was very, very early on. The systems at that time were not near as advanced as they are now. And so I started practice in 2006 and started robotics in 2012. So I've been doing robotic surgery for about 10 years.
Nice.
Wow.
Yeah.
So how does that all work?
So, the easiest way to describe robotic surgery to people is I start off by saying robotic surgery is like laparoscopic surgery on steroids. Now that's a very non-scientific way of explaining it, but here's the way that I explain it to my patients. And patients are very aware of, technology now. Laparoscopically, as you all saw, you've had some surgeons and watched the laparoscopic surgery. So we put trocars in the abdomen, little tubes, fill your belly up full of CO2. So we've got room to work, and we put instruments in those tubes. And they're like straight sticks. On the end of there may be a grasper or a needle driver, a pair of scissors, or whatever we need to do, a stapler, but they're straight sticks. And so we're limited by moving it side to side, in and out, or rotating it, right? We are also fighting the resistance of the abdominal wall. So some people, their abdominal wall may be this thick. Some people, their abdominal wall may be this thick. Obviously, if we do weight loss surgery, we're dealing with larger patients, bigger, thicker abdominal walls. So I always tell patients, if I sent you to work today and I put a cast on you from just beyond your wrist up to your armpit, and I asked you to do your job like this, whatever your job is.
I just got a mental picture.
You come home, I'll take those casts off of your arms and you go back to work and you do your job. Tell me which one was, which you said you were more accurate and more precise.
Right.
Like, well, duh. Robotic surgery, we use small trocars. We have instruments that load. The robot doesn't touch the patient. The robot is connected to the trocars and the instruments load. But I sit at a console and I have complete control of those instruments, but I also have complete wristed motion too. So when my hand does this, the tips of those instruments are completely wristed. I can see inside of a patient 10 times magnified than I can laparoscopically or with the naked eye. I can see in 3D and HD. And I don't say 3D like, oh, cool, like it's a 3D movie, but we see the world in 3D.
Yeah.
We see depth. Like right now, I know that wall's behind you, but I can't see depth perception on the screen that I'm looking at. I see inside of you when I operate robotically in the same depth perception that I would see the world.
Nice.
So the accuracy of working in a millimeter space is going to be much more precise.
Yeah.
Wow.
And then I'm sitting at a complete stable platform. So, I've had days where, if it was a sleeve day, I've had days where I've done 9 sleeves in one day. Now, can you imagine the fatigue that I would have in my arms at the end of my day?
Yeah.
Laparoscopically, robotically, I feel exactly the same. So the force of a tremor is not strong enough to move the robotic instrument. I have to know where to put that instrument, but everywhere I put that instrument and my arms sit there resting, a force of a small movement will not move that instrument. It requires a stronger force to initiate the movement. So wherever I'm placing it, it's completely still and stable.
Nice. Wow.
So there's a ton of advantages of, staplers, the stapling technology that we have robotically that you can only experience if you do these surgeries robotically, because the robot has thousands of computers inside of it. When you all had your sleeve, they used a stapler. You all saw a stapler used, I'm sure, in the surgery.
Yeah, we call it the gator.
Yeah, we call it the gator.
Yeah, the gator.
Yep, exactly. So staplers are really cool instruments. We've used those for years in surgery. That's not new. In a nutshell, we take a stapler, we clamp tissue, it compresses the tissue, and it fires rows of staples and fires a blade between those rows and separates the tissue so it's stapled closed. But in laparoscopic surgery, we have to guesstimate what size staple we need. So we have different colors of loads that correspond to different heights of staples. So if I want to staple 300 sheets of paper, I better pick a stapler big enough that will go through all the sheets and form, or they'll come apart.
And
if I need to staple 100 sheets of paper, I don't need to use a stapler made for 300. It'll form, it'll hold your handouts together, but they're going to be loose. So the first example would mean if the staple's not long enough, your tissue comes apart. That's bad. Or if I just err on the side of caution and I pick a big staple every time, it's not tight, your tissue bleeds. So in surgery and laparoscopic surgery, we make good but educated guesses on what load should we use. The robotic stapler that we use, which is fairly, technology that's come out over the past few years. So this stapler is connected to the tissue. When I clamp the tissue, that stapler knows what load I chose. It will compress that tissue, and it will not fire that stapler until that tissue is compressed based on the staple height that I chose.
Holy crap.
And so in one of you, it may pause 6, 7, 8 times. Every few millimeters, it hits another segment that's too thick, and it compresses it. And if it can't compress it over time, it gives me an alert. It makes me remove that stapler, and then I upgrade to a higher stapler.
Nice.
So why would I not want to be able to make the best refined staple line that I can every single time?
Love that.
Now, laparoscopic surgery is awesome. I'm not sitting here saying that whoever's doing it laparoscopically is doing it poorly. I'm just telling you why I made investment in a lot of hours, because it's not like you can just sit down and start doing it robotically. You're learning, you're learning a lot of stuff that's new to you. But there's so many advantages to the patient. There's advantages to me to be more precise, to be more efficient. I can do more surgeries and feel the way that I do. I definitely think that it will extend my career because I don't have the wear and tear on my body.
Right?
Absolutely.
Yeah, you would have to get fatigued like doing that many in a day.
Well, and with laparoscopically, you're standing. You're, like you said, you've got those like casts on your arms and you're trying to do like that's exhausting all in itself.
And laparoscopically, I'm dependent upon assistance. So traditionally, if you see somebody that had a sleeve, they're going to have 4 to 5 small little incisions.
Right.
And if that's done laparoscopically, 2 of those incisions were used by the surgeon. 2 of those incisions were used by the assistant. The robot has 4 arms, but I control all 4 arms with a series of pedals and my hands. I assist myself, retract, So my assistants sit there in field and all they do is exchange instruments when I ask for a needle driver in place of a grasping instrument.
That's pretty
And I have great assistants, but nobody knows what I want better than me.
Right.
Nobody knows where I want that camera moved. And the time it takes me to tell somebody where I want them to move it, I've moved it there and I've done 5 more steps. And so there's just so many advantages that we can give patients. And it's really cool technology.
So how long does it take you about on average to do like a sleeve surgery with the robotics?
Yeah. So, I mean, we have apps that link to the robot that really, we can review our times, our efficiencies and everything. So sleeve, my average time is going to be just barely over about 30 minutes.
Nice.
Oh, wow. Okay.
And a bypass is going to be probably closer to an hour and 10 minutes. Now there'll be variations, some are more complex and some are easier.
Awesome.
But what the robot does is it really narrows that variation.
Right.
So I might be able to do my fastest sleeve laparoscopically as fast as the robot, but the longest might have been a bigger gap where the robot it just makes it very, very predictable.
I like it.
Which is nice when you're trying to schedule days and how many patients can I take care of today and how long is it going to take me to do this? And, anytime as surgeons we can make things reproducible, we know that typically leads to better outcomes.
That's so amazing.
I like how efficient it is.
Yes. So I just want to hear a little bit about how you got started on TLC.
Yeah. How did that all happen?
Because I have been dying to ask this question because I'm like, how did that come about?
Seriously.
It was really just by chance. I was in my office one day, this is a few years ago now, and my office manager at the time said, "Hey, somebody from the Discovery Network called. They want you to call them back." And I'm like, "Okay." And I threw it on my desk. Someone from another production company had reached out to me years ago. And gosh, this was before Zoom. This was when we were Skyping everybody. And had an idea for a pilot show. And we kind of went over some stuff, and then I just felt like the direction that it was going, really what they wanted to hear or what they wanted to see had very little to do with what I did for a living and more to do with maybe some of the negative aspects you may want to call it. I don't know. But it wasn't for me. I said, thanks, but no thanks kind of thing.
Yeah.
So when I see this again, I don't really put too much thought about it. And about a week later, my manager said, "Did you ever call that number back?" And said, "You know what? I didn't. I actually slipped my mind. I've just been busy." And one of the girls that worked in my office said, "I wonder if it's about 1,000-pound sisters." And I'll be really honest. I've told them this too. I said, I had to say, "Well, what is that?" I didn't know what that was.
Yeah.
So I called, and it was the production company that was involved with the show. And they wanted to talk to me and wanted to know if I would be willing to take them as patients. Obviously, Amy had surgery. Tammy had not had surgery. Chris was interested in having surgery and kind of become involved with them. So there's a lot of conversations back and forth. And I went to my CEO at our hospital because, there's some legal stuff that has to take place on the hospital. Hospitals are very focused on trying to make sure that, you're getting TV crews and all that stuff. It changes things some. So I sat down with him and he said, "Do you want to do this?" And he said, "If you want to do it, we'll support you." He's like, "It's going to be a lot of work on my behalf, but if you want to do it." And I told him, I said, "You know what? I want to tell you the main reason I want to do this is these patients are from within our own state."
Yeah.
And I said, I'm tired of sometimes watching things where it feels like, especially from maybe a rural community or maybe a state that seemed maybe smaller than some larger states, that the patients have to be kind of taken off to the big city to get premium care. And, I tell people all the time, I say, valet parking and waterfalls in front of hospitals and Taj Mahal buildings don't take care of people. The people inside 4 walls take care of people. And there's good doctors in the big ones and there's good doctors in the little ones. And I said, I know we can take as good, if not better care of these patients as anybody can. That's really why I want to do it. And he's like, "Okay." So they had seen some maybe stuff that we had done really through just our practice. some testimonials. I guess they'd heard me speak. And then obviously they'd done some research on the volume of surgeries that I'd done and our practice in general. And that's really how it came about. I never had sought them out or anything like that. But, it's been great. It's been a new process for me. I was very adamant that like, I'm going to be me. And I don't know if that's going to make for very good TV or not. It may not, but I'm going to be me. I'm not going to say things that I wouldn't say to a patient. I'm not going to say things to a patient in a different way than I would normally say them, good or bad.
Good.
I'm not going to change. I'm not going to compromise what I would expect from them. And this is how I treat people. And, and that's what I'm going to do. And they were great. They were very supportive of that. They were like, no, that's what we want you to do. We're not going to ask you to compromise your principles of how you care for patients, how you talk to patients, how you handle certain situations that may arise. And that was my biggest concern. And then from that standpoint, I think it's been great. And I've been very pleased with how that's gone.
Yay.
Oh my goodness. I love the fact that like, you're like, I want to do this, but smaller state, get the people in here because that's so true. After you said that, I'm like, yeah, they all do that. They're all like, go over to this fabulous place to get it done. And it's like,
well,
and it's not that they don't do a good job either, but I think, it was just that was something that was really important to me. So, I don't know.
Well, it helps us build more confidence in our own states though, by you doing that. And that's a big deal because it's like, you don't actually have to, there's gotta be a couple people qualified at least in your state.
You would think.
Like there's just some research you might have to do, but like just know that you can find help in your own state.
Well, and I had surgery in a smaller town. So we live in Salem, which is, about an hour south of Portland, which is huge. And Mel had surgery in Portland.
Yep.
I got you.
I went to McMinnville, which is about 45 minutes away from us, but it is a small town.
Yep.
And I had great care through that small town. And there was a point in my surgery journey where I might not have been able to have my doctor that I had worked with for 6 months do my surgery. And I was like, no, I don't want to go to a bigger hospital. I want to have you do it because you trust the surgeon.
Yeah.
And,
absolutely.
You develop that rapport with them, the rapport you were talking about with your, PCPs. That's the same rapport that you should be cultivating with your surgeon because you should have that infinite trust that they're going to take care of you because that's their job.
Yeah.
And so I'm glad that you have really advocated for that.
Because
I couldn't agree more. I think our specialty is different than any surgical specialty where we're asking people to make, I tell patients all the time, you have to find a program that you can have a long-term relationship with. You have to have trust with. And it's my job as a surgeon to create an environment that you are as likely to come when you're messing up as you are when you want to brag about a before and after picture.
Yes.
If I only make you feel good about yourself when you're hitting my numbers, then I'm not doing my job. I'm going to be honest with you and I'm going to be direct. But you should never be hesitant to come back because you're going to be afraid that someone's going to make you feel less or belittle you or yell at you or whatever. I've failed as your surgeon. It doesn't matter how good of a surgeon I am with my hands. It doesn't matter what my outcomes are like. And I'm very proud of the number of surgeries that I've done and what my outcomes are. But I think you have to build that rapport. And we're asking people who are many times battling insecurity issues. They're battling issues where they've been ousted by their doctor, their family, whatever that may be. And by the way, go through sometimes a 6-month process and all the work involved to do that. And so I think it's on us to put in that extra effort outside of just the surgical principles to build that relationship with them. And I will say probably the biggest compliment that I have taken from the show is the feedback that I've got from people about how I've approached the patients and Tammy specifically. When maybe Tammy wasn't always doing what we wanted her to do, or maybe Tammy wasn't ready to do what we needed her to do. I remember one time somebody said, why don't you just give her an ultimatum? And I'm like, well, I did give her an ultimatum. I said, we have to do these things before we go to the operating room.
Yeah.
But who am I to tell a patient that their timeline has to be my timeline.
Oh, you know, I like that.
I'm here every day. I'm not going to give up on you. I'm not going to bend my rules and give you something that I don't think is in your best interest if you're not ready for it.
Yeah.
But who am I to say, well, you didn't do this on this timeline that I set, so I'm out. I'm a bariatric surgeon. I'm there every day, every week. And when we're ready to do that, that's what we'll do. And that just seems common sense to me.
It does,
but I think it's been nice that patients have seen that, and maybe they haven't heard that in other places and know that that's a possibility. And there are other places that will treat them that way too.
If I didn't like you enough already, I really like you after that whole thing. Like, I appreciate that, because I think sometimes as bariatric patients, we feel like if we're not moving at a certain speed, we're not making progress.
Yeah.
But then I think also at that same time, if you're not ready for it, it's always going to be there. You have to make sure that you are 100% ready for this process, because I think a lot of people jump into it because they're like, if I don't do it fast, I'm not ever going to do it. And it's like, if that's the way you're thinking, maybe it's not the right time frame. Maybe you need to take a little bit longer to do it, so that because I know when I walked into that hospital on the day of surgery, I was 100% ready. And it didn't mean I wasn't nervous, but I knew that I was doing what I needed to do.
Yeah.
And I was 100% on board.
Yep.
Right.
And so I really appreciate that you said that.
Well, yeah, because like everybody has like a different learning curve too. Because I feel like you have to learn a lot through these processes, whether it's 3 months, 6 months, a year. Like, it doesn't matter how long it takes, as long as you finally learned all the things. Because if you don't learn all the things, then you're not going to be successful. So it's okay.
Absolutely.
Yeah.
It's okay to take your time. Just like we say.
Just because you hit a number doesn't mean you're ready.
Correct.
And just because you don't hit a number doesn't mean that you don't have the ability to become ready.
Yeah.
And I think that that's important to consider both directions. So
100%.
Yeah. Just like it's okay for you to shop around for a surgeon, to, like you said, to like make sure that you have that connection, you feel comfortable with them. You want to make sure that you have that infinite trust in them, that they have your best, what's the word I'm looking for?
Interest at heart?
No. Whatever. So they have your back no matter what.
Yeah.
Right.
That, so it's okay to shop around. If you don't connect with a certain surgeon or a certain nutritionist, how likely are you going to go back in if you're, like you said, have problems? So say you're not at a stall and you've done everything right and you're not sure what's going on. How likely are you to go back if you don't feel comfortable talking to them?
Yeah.
Right. Absolutely.
So,
absolutely. And that doesn't mean that you have to tell them what they want to hear.
No. You
have to have empathy for people and tell them the truth. But there's different ways that you can say the same thing. And I think, when that person said that to me, it was a message, on social media, you need to get, I wanted to say, you want the ultimatum.
Yeah.
You just want it to end by season 3 so you can see that's not how this works. This is real life.
Yeah.
So, the ultimatum is, I will not operate on you if X, Y, and Z have not been accomplished, because that's not what's best for you. I have to set you up for success, both short-term and long-term, that you will not harm yourself, and be convinced of that. That's the ultimatum. The ultimatum isn't, don't come back because you didn't hit a number.
Right.
That is wrong.
Yeah.
You know?
Yeah. And that's where, the patients have heard that over and over again. They've been, every diet you're on, if you don't hit a certain goal, well, that's the end of that diet. Yep. Okay, well, let's just eat some more. And like, we're going to fill that void that we're feeling because we just, failed, in quotation marks, because you haven't failed because you're still trying. But I think that's where your program or how you deal with patients is so different because of that. Like you're saying, do it the correct way, and I'm not going to give you any leeway on this because the rules are the rules, but I'm here for you.
Yeah.
Yeah. And obviously there's one of me and there's lots of patients and we're extremely busy. So it's my job. I can't be the person that conveys that message every time the message needs to be conveyed. It may be multiple times in a week for certain people.
Yeah.
But that everybody, I'm surrounded by great people. I learned that lesson a long time ago. One of the big keys to success is surround yourself with really smart people and people that care about the same things you care about. So I have great PAs and nurse practitioners and dietitians and all the people in our staff, from our nurses and our MAs and our coordinators and our lead coordinators and everything, even the people that answer a message on a Facebook page, they have that, that this is our rules guide, and I don't have to reinforce that because that's just the kind of people that they are.
Yeah.
But it's important because that message has to be consistent from everybody. And I'm sure we've all had bad days. Somebody's answered the phone, maybe short, something bad happened at home or whatever. I'm sure I've made plenty of people frustrated at me too. I make mistakes just like everybody else, but I think that's important. That I always try to say, we want the patients to feel like that because they're already struggling. That's why they're here.
Right.
It's okay to struggle. Let's just try to find out how we can help them not struggle.
I love it.
I love it. Well, Dr. Eric, is there any tips that you would like to tell our listeners before we go?
Listen to you guys. You guys are giving them a ton of information. No, I mean, seriously, I will say this, and I mean this, I probably was exposed to this community on social media a little bit born out of my participation on the show. I'll be the first to tell you, if you rewind years ago, I was almost anti-social media from a medicine standpoint. I always say as doctors, we kind of dread the doctor Google seeker, And I realized by kind of researching on my own and looking, people like you guys and other patients that have, platforms of all sorts, and I've met other surgeons through this that I haven't met face to face in person, but we've commented on each other's things, and patients and dietitians and prospective patients and surgeons, and it's really, really cool because people connect differently with different people. And there's so many great resources. And finally, I said, I can sit around and complain with maybe some of the messages that are out there before I saw all the positive it is, or I can do something about it and I can contribute a little bit for myself, as well. So I think what you guys offer for people is really, really cool. And it's awesome because it gives them the ability to connect and kind of have that support system. You've said earlier, you have bad days, you have bad weeks, you have bad months. And patients need to know that it's okay. It's normal. It doesn't mean that you failed. You just get back on the horse. It's progress, not perfection. And everybody else feels the way that you do, you know? And so I think really the best advice that I can give is find a surgeon that you can trust and that you can build a relationship with. You need to know their volume, You don't want a nice surgeon who's only done 5 cases, but somebody who's well experienced and well trained, but they also need to be able to how to help you with your bad days as easy as they can with your good days, and then find a strong support system. And if you're lucky enough to have a family that will do that, great. If you're not, that's okay. Let them learn through your success and find people like you all and other people that they can find online to join up with and really help them through it.
I mean, for reals, if you just find your people, like that's, I noticed for me was a big deal. Like once I found the community, because I had my surgery almost 7 years ago. So like 7 years ago, this community was not like this or existing. So it's insane how much like camaraderie there is. Like everybody just wants to help because I think we all know what it feels like to be that bigger person and just wanting more.
Well, and I didn't realize how I was telling Mel that I was kind of almost subconsciously not looking as much or as deeply into Instagram as I normally would over, about a month, maybe longer, because I didn't want to look at myself not doing what I knew I was supposed to be doing.
Yep.
And when I'm in this community and I'm commenting and I'm looking at people's photos, I'm getting motivated by them. So it's
accountability.
Much, exactly. Yeah. And so I was like subconsciously not looking at it and not being as present. And I was like, I know exactly why I'm doing it now. Like it just smacked me in the face. And I was like, oh man, I knew there was a reason. And now that I've been back in it, like full force, like I went back to the gym for the first time this morning and I loved it. And it was just like, it keeps me, as much as we motivate them, they motivate us.
Oh, yes.
And that's the biggest thing that I get out of this podcast is just the constant motivation and interaction with people, because it doesn't matter if you're just saying, hey, love that episode, or you have a really, problem that you need answer to. It's just so motivating.
It is. Well, you motivated me this morning. So I was like, I need to get back to the gym too.
Oh yeah. Cause I was like,
that looked like fun. It looked like fun.
Weren't you supposed to sign up for the gym over the weekend so you could go with me?
I was.
I'm just pointing that out there.
We get that from our patients too. I'm sure other surgeons would tell you the same thing. We get that from our patients too. I love to do what I do and I love to operate. I'm the luckiest guy in the world to get to do a job that I love so much. But there's days when you're tired and there's things are piling on and you get busy and you get caught off guard. And then that you see that patient that you've impacted. And, I fly out in the morning to Atlanta. I'm going to train some surgeons there. And as well as some people that work for Intuitive that are becoming bariatric surgery reps too. But cool. I love that side, but I enjoy helping patients just as much. And it has nothing to do with talking about a procedure or a skill or anything like that.
Yeah.
Because ultimately it still reaches the end goal of helping people. So I get it. And I get that back from patients as well. So the simplest thank you, man, can make your day. So I'm right there with you.
100%.
Yeah. We got a message today and I was just like almost in tears. I was like, man, like that just made my whole day. Like, and I was already pumped from the gym. And then I read that and I was just like, they don't know how much that means to us, just reading, that we have helped them become so prepared for surgery that they feel like they've got a handle on it. Like
it means a lot.
It does. It means
it's like, it's working. Yay.
Yep. Makes it all worth it.
Exactly.
Well, thank you so much for hanging out with us, Dr. Eric. We really appreciate this opportunity. So,
yes.
So guys, pleasure. If you want to watch this, go to YouTube right now. It comes on your phone automatically. You don't even have to download it. Click the button.
That's her bargaining chip.
It is. Just type in Arsley Live Podcast and then hit the bell and subscribe. And then you get all of season 2 through 5 so far. And you even get unboxings. You get taste testing.
Yeah, there's a lot of stuff over there.
A lot of stuff.
And don't forget to check out patreon.com/OSLP. And also don't forget to go to our website. Yes, we have a website.
Yeah.
It's arsleyoflifepodcast.com. We have merch. We have all sorts of stuff over there.
Yeah.
And it's constantly growing and changing. So make sure to sign up for our mailing list because newsletters go out when new stuff goes out. And it's constantly changing and evolving. So check back often.
Alrighty, guys.
We love you guys.
And we'll see you next time.
Bye.